Good afternoon, sir. My name is Mario. I'm going to be a nurse practitioner today. I'm going to be taking care of you.
Okay.
So now today we're going to be doing the respiratory assessment. Okay, so for the purpose of this video, the patient is going to keep a shirt on, but we should always do the respiratory assessment without a shirt. Okay. So the first thing we're going to do, we're going to be inspecting. We're going to follow the steps. First, we're going to inspect the chest for the configuration, the AP ratio. For any signs of barrel chest, pigeon chest, tunnel chest. We're going to see the symmetry of the chest, the rate of the breathing, the rhythm of the breathing, any signs of respiratory distress like cyanosis, or the patient feeling anxious, diaphoretic. We're going to inspect for all those signs, any rashes in the skin, any lesions, any masses throughout the chest, throughout the cavity. So that'll be for inspection. Now we're gonna go ahead and palpate again for the purpose of this video and the camera. I'm gonna do the entire respiratory assessment in front, and then I'm gonna ask the patient to turn and do the posterior aspect of the chest. During clinical practice, of course, we will do both at the same time for the time for better timing. And after inspection, I'm gonna go ahead and palpate. I'm gonna put my hands on you, okay? So you're gonna palpate all the chest wall, and for any costochondral tenderness, for any crepitus, any air trapping underneath the subcutaneous tissue. Let me know if you feel any pain or any tenderness, okay? So we're gonna palpate all the areas of the chest cavity. No pain?
No
pain. Not going to deny any pains, and no crepitus felt. So the next step for palpation, we could do tactile fremitus. So tactile fremitus, we could is the vibrations in the chest wall up on the patient saying 99. Okay, so we gotta feel the tactile fremitus with this aspect of your hand, or you could also do it with the tip, 3 or 4 fingers. The most important thing is to compare both sides. Tactile fremitus should be symmetrical. You should sometimes feel vibration. If you feel increased vibration in one side, it may be because of consolidation or because of pneumonia. If you feel decreased tactile fremitus because the patient has COPD or any other disease. Okay, I'm gonna start palpating. Okay, and I'm gonna go like with both of my hands. Let me see if you can see me. I'm gonna go right here.
99.
Say 99, please.
99.
99. Okay.
99.
Okay, so I felt symmetric tactile fremitus throughout symmetric and bilateral in both aspects of the chest cavity. After tactile fremitus, we could also do chest excursion. So that's gonna tell me how symmetric the chest expands. So we're gonna put in the costal angle where the rib cage ends. We're gonna put both of the hands, and we're gonna make a slight skinful, and we're gonna ask the patient to take a deep breath. Can you please take a deep breath? So we see symmetric movement of both of my hands to the sides, how the chest is expanding. If we see that the chest expansion is more on one side than the other, then that's an abnormal finding. After we do the tactile fremitus and the chest excursion, now we're gonna go ahead for percussion. So after we do percussion, when doing percussion, we're gonna do all lung fields. Okay. The normal finding is resonance that we're gonna feel throughout the lung fields. If you hear any dullness, it may be consolidation or signs of pneumonia. If you hear any hyperresonance because of COPD or emphysema. So we start at the apex of the lungs, right above clavicle. So both sides. We go down. We're gonna do it we're gonna compare both sides. We're gonna do it in the costal margins. You gotta do it in all lung fields, okay? Let's remember, I'm gonna move this way. All right. Okay. Gotta remember that the left lung has 2 lobes, the right lobe has 3 lobes, so we gotta percuss all of them. So in this case, it was resonance all throughout. After we do that, we do that's it. We compare side to side on the percussion. Now we're gonna auscultate, okay? So we're gonna be auscultating with a diaphragm over stethoscope. So we're gonna be auscultating all aspects of the lungs. We're gonna should hear the different lung sounds. Okay, we got the different lung sounds in tracheal, bronchial, bronchiovesicular in this area, and vesicular in most of the lung fields. It is easier to listen to the lungs in the posterior aspect, but you also gotta do the anterior. Okay, so every time I put the stethoscope on your skin, can you please take a deep breath? And if you feel dizzy or if you feel any discomfort, let me know. We can take a little break so you don't hyperventilate. Okay? Mm-hmm. Please take a deep breath. Again. Yeah. Okay, so all clear lung sounds all throughout the lung fields. We gotta pay attention when we use the stethoscope. Do it in a ladder mode, down and then pass and down. You gotta compare both sides. So they're both clear all throughout throughout the lung fields. Now I'm gonna ask the patient. Can you please turn around? The other way, so I can. Okay. So now is the posterior again. The inspection should be and all the respiratory assessment should be without a shirt. So inspect the same thing. Inspect any masses, any lesions, any rash, any swelling, any abnormal findings by inspection. The AP diameter. So now I'm gonna palpate, okay? Any coastal condyle margin, you let me know if you have any pain, okay? Mm-hmm. The joints, you palpate, in between the ribs. Any pain?
No.
Pain? No pain? No pain?
No.
Okay, no pain. Open palpation in all lung fields, okay? Now we could do the same thing, tactile firmitas and chest expansion, chest excursion, okay? So the first thing we're gonna do tactile firmitas, and the same thing, consolidation is symmetrical. It should be consolidation is increased and the vibrations, and the most important thing is that we check that is the tactile firmitas is symmetrical. Okay, so when I put my hands on your back, can you please say 99? Mm-hmm. Okay, so I'm gonna do it this way so you can see it. Can you please say 99?
99.
We can do it with this.
99. 99. 99. 99.
Okay, so now that I'm down here, so that the tactile firmitas was symmetrical, equal, bilateral. Now we're gonna do chest excursion. So we're gonna around the 10 rib, around the 10 rib. We're gonna put both of our hands in this motion. And then you can see it like this better. Both of our hands, and we're gonna check for chest excursion. We're gonna put both hands in the middle. Do a little skin fold. Can you please take a deep breath? You're gonna see both hands separate, symmetrical. That's a symmetric chest expansion. That's what we're looking for. That's a normal finding. We see the same thing. One more is abnormal. After we finish with the palpation, we're gonna go ahead and do percussion. It's the same thing. All lung fields percussion. Percuss. Actually, for percussion, when the patient is in the back, we can also, can you please, like you're hugging yourself, That opens the scapula and prevents any dullness sound in this area. We can go ahead avoid the scapula and still continue to breathe. Okay, while we're doing this, we also have to check for diaphragmatic excursion. So how this is done is we're gonna tell the patient diaphragmatic excursion. What it is we're gonna see how the diaphragm moves down and up, and open the patient taking a deep breath and exhaling, and that the normal should be between 3 and 6 centimeters the separation. So the first thing we're gonna do is we're gonna tell the patient, can you please take a deep breath? Here it changes to do, and you can breathe normal. You can mark it here, and then that's with inhalation. It should be lower, and then exhale, and holding the exhalation should be higher for the diaphragm move. How the diaphragm moves. So an exhalation, we're gonna move from this point that we found it up. Can you please take a deep breath, exhale, and then hold it? Hold it. Okay, we're gonna go up. Okay, put it right here. So that we'll take a ruler, and then when we measure it should be 3 to 6 centimeters. That will be the normal for diaphragmatic excursion. After we finish the diaphragmatic excursion, we're gonna go ahead and auscultate. So we're gonna auscultate through the lung fields with the diaphragm, apex of the lungs, and go down, noting any adventitious sounds. Okay. Take a deep breath. If you feel any dizziness or you're about to pass out while breathing, please let me know. Every time you put the stethoscope on your skin, can you please take a deep breath? It's very important when we're listening to lung sounds to compare both lungs. Ones to see if the sounds normal or adventitious are symmetrical. Now, we should also be looking for auscultation, depending on the history and everything, for any abnormal sounds like wheezing, rhonchi, crackles, stridor. That'll be more audible without a stethoscope. All those lung sounds. Now, the other two tests that is very useful to do is bronchophony and egophony. Those two tests are done to detect any consolidation for patients that come in with complaining of respiratory symptoms and possible indicative of pneumonia or any consolidation in the lungs. So what we're going to do for egophony is we're going to ask the patient to say the letter E. You should be, if it's a negative egophony, then you should be able to, if normal, you should hear the E as a muffled sound and decrease. If you hear the E changing into an A, that will be an abnormal finding in egophony. Okay? So every time I put the stethoscope in your skin, can you please say the letter E?
Okay. E. 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 E.
Okay. So that it was negative. It was muffled, the sound. Now bronchophony. Bronchophony is be the same thing, but the patient is gonna be saying the word 99. So you gotta listen, and if you hear the sound louder or in one side or the other, then you could consider that as a positive sign. Now you're gonna be saying 99 when I put the stethoscope on your skin. Okay.
Okay. 99. 99. 99. 99. 99. 99.
So 99 should also be maybe louder, but should also be a muffled sound as well. Okay, I think that concludes our respiratory assessment. Thank you very much.